Good afternoon and welcome to Gut Transition's second quarterly webinar, Paving the Way to Adult Healthcare, the new clinical report on healthcare transition. My name is Ann Walls and I'm the project manager for Gut Transition. Our national center is funded by a cooperative agreement between the U.S. Maternal and Child Health Bureau and the Center for Medical Home Improvement, Gut Transition's home base. This is the second in Gut Transition's quarterly webinar series. At this time, we wish to thank the American Academy of Pediatrics, who collaborated with us to develop and promote this event. First, a few procedural notes about today's webinar. All participants except for speakers are on mute. There will be a 15-minute question and answer period after all of the speakers have presented. If you wish to submit a question, please do so in the question box of your screen at any time during the webinar. During the question and answer, I will read a selection of questions submitted and solicit responses from among our speakers, but our time is limited. Those questions we may not get to will be compiled with our responses and posted on our Gut Transition website. I am pleased to report that we have over 679 people registered for today's event. This is truly an indication of the heightened need and interest there is to learn more about systematic healthcare transition. Our participating audience today draws from a national representation of healthcare professionals, youth and families, researchers, and state policy makers. As you will soon find out, we have a lineup of speakers who have a great deal of knowledge in and as well as personal experience with healthcare transition. We appreciate their willingness to share their perspectives and expertise about what is needed for a smooth transition from pediatric to adult care. I will be introducing each of them individually before they speak. We have provided here highlights of the learning objectives that we have identified for today's webinar. I wanted to remind you that an audio archive of this webinar will be posted on our website, and I have provided here the URL for that website. We hope that you will take the time to visit our website following this broadcast. And now, on to our speakers. Our first speaker is Mallory Sear, Gut Transition's I have the pleasure of introducing our first speaker today. Dr. Fan Tate is the Associate Executive Director of the American Academy of Pediatrics, as well as Director of the Department of Community and Specialty Pediatrics. Dr. Tate is a pediatric neurologist. From 1998 to 2005, she served as Bureau Director of Children with Special Healthcare Needs within the Utah Department of Health and was an Associate Professor of Pediatrics at the University of Utah School of Medicine for many years prior. In her presentation, Dr. Tate will be describing the Academy's early and ongoing initiatives to recognize and address the need for healthcare transition. Please join me in welcoming Dr. Tate. Dr. Tate, please let me know when you want to advance the slides. Thank you.
Thanks so much, Ann. And I want to thank everyone and my partners and everyone on the webinar for this opportunity. First slide, please. Next slide. There you go. Thank you so much. So when at the American Academy of Pediatrics, when we're really thinking in terms of healthcare transition goals, we're really looking at goals for all youth. And we're actually looking at the lifelong functioning and well-being and how do we maximize that. When we're thinking in terms of transition, we're looking at high quality, developmentally appropriate healthcare services and that they're available in an uninterrupted and also a planned manner when youth are moving from adolescence to adulthood. As the Maternal and Child Health Bureau describes, care is seamless, effective, and comprehensive for all youth and families during this transition. Next slide. So is the time right for healthcare transition? And I think the answer is a resounding yes. We have the national healthcare reform efforts that are affecting all of us, but also particularly affecting youth and young adults. Transition remains one of the 6 performance priorities for the National Maternal and Child Health Policy. And as you heard Ann say, this webinar is actually being presented by the new National Healthcare Transition Center, Got Transition. In addition, the American Academy of Pediatrics, the Academy of Family Physicians, and also the American College of Physicians, that would be the Internist, were involved in what we're going to talk about today, which is the clinical report. Next slide, please. So the AAP and partners have been involved in transition activities for over 10 years, including the development of a consensus statement in 2002. But in the past 4 years, we've really kicked the transition initiatives up a notch. When we're looking at the leadership of the Academy, I think it's important for everyone to realize that improving healthcare transition was voted a top 10 priority at our annual leadership forum. We've looked at national surveys of our fellows, and that revealed a need for more information and support about transitions. The AAP, and this is an MCHB-funded National Center for Medical Home Implementation, actually commissioned a review of current transition practices and the literature. And about 3 years ago, an AAP transition authoring group was established to develop a clinical report, which really, and you'll hear obviously more about it today, but really to include a detailed guidance on healthcare transition. Next slide, please. So what we learned from our members and from the literature, from surveys, from national sources, is that pediatricians and adult primary care providers need tools and concrete methods to address the barriers and improve care. So what was developed was supporting the healthcare transition from adolescence to adulthood in the medical home. And this was actually published in our journal Pediatrics just last month. And it's important to know that this clinical report was jointly authored by the AAP, AAFP, and the ACP, as well as an interdisciplinary and multidisciplinary group of colleagues. So practical, detailed guidance, including this step-by-step algorithm that you will see on how to plan and execute healthcare transitions for all patients, was what was developed. Next slide, please. So what we plan on doing is getting the word out, as we're doing today, about this clinical report, looking at how we can help implement the successful use of the algorithm. And for those in practice, we're looking at the report and its content to really be translated into diverse educational modalities, such as the webinar we're having today or at our national conference or many other areas. We will be translating it into medical education resources for fellows and residents and otherwise. The report also will inform payment and financing options. And as we move forward, we will be looking at and putting forward the best practices that are developed through the healthcare transition outcomes. So thank you for this opportunity. We're really grateful for our work with the people on the phone and our other colleagues, and I'll turn it back to you, Ann. Thank you.
Thank you very much, Dr. Tate. Thank you for setting a contextual background for this webinar and for our work in transition. And now please bear with me while I scroll back to the slides that we will next be hearing from Mal Sear. Mal is Got Transition's National Youth Project Manager. We are really pleased to have Mallory as a member of our Got Transition team and cabinet. Before joining our National Center, Mal had been associated with Healthy and Ready to Work, the National Transition Center that preceded Got Transition. Mallory has an instrumental role in the launch and management of Got Transition's social media outlets, both within our website and on our Facebook page. She has also served as a consultant to our Got Transition Learning Collaborative teams, where she's coached families and youth to take a more active and visible role shaping practice-based healthcare transition policy, process, and tools. Mallory will be providing her views on healthcare transition as a young adult consumer. Mallory?
Contributed to this report and for making this webinar possible. We have an amazing turnout, which is so exciting to see. So I'm just going to talk a little bit about my experience with transition and why it's important for families and young people to be thinking about. First slide. So why is it important? As I have talked to a lot of parents and youth and providers about transitioning to adult doctors and healthcare transition as a whole, a lot of times you hear, well, I don't want to go somewhere different. My doctor is comfortable. He understands my condition. Or nobody is comfortable taking my unique health needs. But there are a lot of reasons that it's important. And it's actually a really exciting thing because, for one thing, youth with special healthcare needs and special illnesses that used to be just pediatric are growing up and becoming adults. And that's really exciting to see. Also, when these young adults don't transition to other providers, some of their health needs that pediatric providers don't think about could go unmet, such as reproductive needs, talking about family planning, which some people, regardless of disability, would be interested in, and just how to maintain health and wellness through the aging process. So that's really crucial. And also, within the transition process come the skills that are needed for young adults to be at the center of their own health care and to learn what it means to be an informed decision maker and be able to make important choices regarding their health. Next slide. So as I was doing this work and getting involved with the Learning Collaborative, I realized that having a successful and positive transition experience is sort of hard to come by. And my experience has actually been really positive, and I didn't realize how rare that was, I suppose. So in my personal experience, both with my primary care provider and transitioning and specialist, I actually feel that my health has improved, my experience with healthcare has improved, and that's for a lot of reasons. First of all, I was very involved in selecting my new providers. One was from a referral from my specialist, and the other was sort of chosen by my insurance company, but I went through a process to see that it was someone I was comfortable working with. And through that process, we really built relationships and talked about my needs and concerns and their experience and whether they were willing to work with me about that. And it has been really positive, and they have been excited to learn about my condition and help me progress and see my health thrive. So within that, it's been a really positive experience. And also, as we move forward to make health decisions, I feel more committed to doing the things that we discussed because I was so involved, and it was something that we came up with together. So having that respect and strong relationship with my providers has really been wonderful. And so for families and youth, I really encourage you to take that step and build those relationships, and you would be surprised what can come of it. So with that, I'll give it back to Anne, and we can talk about the report. Thank you.
Okay, thanks so much, Mal. And we always appreciate hearing a youth perspective, and we built it into all of our healthcare transition improvement strategies because it's so important to have that perspective. And now bear with me, and my apologies again for our needing to scroll through these slides to get to our next speaker. I welcome another member of our GOT Transition Cabinet, Dr. Patience White. Dr. White is the Vice President of Public Health at the Arthritis Foundation, and she's a leader in the field of assisting youth with chronic illnesses and disabilities in their transition to employment, independence, post-secondary education, and adult health care. Dr. White has served as the Executive Director of the Adolescent Employment Readiness Center at the Children's National Medical Center in Washington, D.C. that transitioned over 2,000 youth with special health care needs into adult health, education, and employment systems. She continues to play a key role in facilitating cross-system collaboration around the issue of transition at the local and national level. Currently, Dr. White is the co-principal investigator for one of the initial GOT Transition Learning Collaboratives in Washington, D.C. She also served in the writing group for the clinical report for healthcare transition and is a co-author. In her role as a GOT Transition Cabinet member, Dr. White provides a liaison to the American College of Physicians. Dr. White will be offering information on healthcare transition needs and opportunities from the perspective of an adult practitioner. Please join me in welcoming Dr. Patience White. We'll need to get back to Patience. At this point, I am going to move forward to introduce Dr. Kyle Cooley. Dr. Cooley is the Medical Director for the Center for Medical Home Improvement, Co-Director of GOT Transition, and Chief Medical Officer for Crotched Mountain Foundation. Like all of our speakers, Dr. Cooley's resume includes a number of leadership, teaching, and authoring roles that make him an expert in both medical home and healthcare transition implementation. Most notable for today's webinar is that Dr. Cooley is a lead author of the clinical report that drew many of you to today's webinar. Dr. Cooley will be providing a bit more information about the need for improved health care transition services, and then will walk us through the clinical report and algorithm. Carl?
Thank you very much, Anne. And actually, Anna, you might back up to Dr. White's slides, because she and I have made this presentation together in the past, and I might just walk the audience through those. We had intended to portray the needs around transition from the point of view of youth and from the point of view of families, and then from those of pediatric and adult health professionals, so that there are data that we have available from a variety of these perspectives. One of them is how prepared are youth for managing their care in the adult system. And the next slide, please, Ann. These are data collected by Maria Ferris in North Carolina in a nephrology clinic for adults, including young adults with kidney disease. And some of the results, I think, are stunning in that only 45% of these young adult patients were familiar with their medications. 30% had knowledge about their condition. And I think tellingly, in terms of preparing young adults to be more in charge of their own health in the adult healthcare system, 20% of the time these nephrologists saw young adults asking questions, while 69% of the time, if their parents were still involved in visits, the parents would tend to ask questions. And 40% of the young adults believed that transition was a difficult experience for them. Next slide. And how about adult providers? The next slide provides some data from our home territory here in New Hampshire, collected by our Title V program and its transition project. It looked at responses from 180 adult providers. 81% were family physicians and 9% were internists, and there were some nurse practitioners and med-peds physicians involved as well. And 57 of these individuals, 46%, rarely to never received a transition summary or call prior to their first visit with a young adult. They indicated that they had issues with staffing and reimbursement and time, inadequate support from specialists to provide care for young adults with chronic conditions. As one might expect, these adult providers were more comfortable with conditions that they had familiarity with in other adults, such as asthma and hypertension and diabetes, and much less comfortable with complex conditions of childhood onset, such as cystic fibrosis or autism. They all indicated, nearly all of them anyway, indicated that a written summary would be helpful and support from specialists would be important. And 91% wanted an opportunity to speak directly with the prior, meaning the pediatric provider. 84% would have liked some information about the chronic condition involved with the child. The next slide. Internist perspective on transition. This is selected random selection of internists in 2009, indicated that they did not have the training and needed guidance in congenital and pediatric diseases. They wanted the family engaged when the youth was unable to be their own healthcare decision maker. They had difficulty meeting youth psychosocial needs and the family's higher expectations for time and attention needed for care, which they might have received in the pediatric world. The feeling they had was that youth were often, meaning their young adult patients, were less mature and less ready for decision making in adult issues. They found there were barriers for financing and infrastructure, and sometimes lack of local services that a young adult might need. And they pointed out that from their perspective, transition from pediatric care was not well coordinated. The next slide. And so this sort of transitions into a little more information about family and pediatrician's perspective, and then we'll get into the meat of the clinical report. The next slide, please. How about families? Many of you on the call are probably familiar with the National Survey of Children with Special Health Care Needs, the most recent of which was conducted in 2005 and 2006. And in this, it was clearly evident that over half of families in the United States who had children with special health care needs in this transition age group did not receive the supports needed to make appropriate transitions to adult health care, work, and independence. Only about half of them had talked, had their healthcare providers talk with them about seeing adult healthcare providers. Less than half of their physicians talked with them about the healthcare needs as their child becomes an adult, and only about 21% of primary care providers discussed with them how to obtain or keep some type of health insurance coverage as their child matured into adulthood. The next slide. And pediatricians were surveyed in 2008, as Dr. Tate mentioned in her introduction, about healthcare transition. And I won't read all of these to you, but again, less than half of the surveyed pediatricians assisted with a referral to a family physician or internal medicine physician. Only about a third discussed the issues of consent and confidentiality, which come into play as federal law as of age 18. And looking at the bottom group of bullets on this slide, only a quarter would create a portable medical summary. Less than 20% assisted in identifying insurance options, and only about 12% created an individualized healthcare transition plan. New paragraph, or new, sorry, next. These pediatricians identified barriers, some of which were similar to those observed by the adult providers. 85% perceived adult care as being fragmented and difficult to navigate. 80% noted the lack of adult primary care and specialty care providers ready to take on young adults, particularly those with special health care needs. 80% of them described a difficulty breaking the bond with adolescents and their parents with whom they'd had, to that point, a lifelong relationship. And of course, as is often the case with providing services such as transition support, 3/4 identified issues of lack of reimbursement for these activities. The next slide, please. So this slide just I'll touch on briefly, but it identifies some of the alignment, actually unfortunate alignment, between adult healthcare providers' needs and pediatric healthcare providers' actions as portrayed in the survey. There's a almost a complete disconnect in many cases between what adult providers are looking for and what those of us in the pediatric world are or have been providing. And the bottom boxes indicate, the need on both adult and pediatric sides for the existence of a fully functional medical home for youth and young adults, the need for increased knowledge about pediatric diseases, and for assistance from pediatricians and others in the pediatric world to provide some of that knowledge. And the agreement among adult and pediatric providers that more adult providers who are willing and ready to undertake the care of young adults, particularly those with special health care needs, is needed. Next slide, please. So the healthcare transition clinical report is, I think, an exciting development. We were all very excited to see it in print in the July edition of Pediatrics. I should say at the end of our webinar, there's a web link for those of you who don't have a copy of the clinical report where you can download the PDF of the report. It serves as a basis for the 4 healthcare transition agenda items of the Academy of Pediatrics, as Dr. Tate has pointed out. This report was developed by a diverse authoring group that included youth and families. It included policymakers as well as representatives from the pediatric, family medicine, and internal medicine communities. And prior to its publication, it was reviewed by a very large and diverse constituency whose thoughtful comments were incorporated wherever possible in the final version of the report. Next slide. I think it's important to point out that this clinical report targets all youth. The feeling of the authoring group was that youth both with and without special health care needs were in need of guidance into the adult health care system and its use. It is developed in an algorithmic structure, as you've heard, which provides a logical framework built around individual encounters in an office setting. There's a branching in the algorithm for youth with special health care needs, leading to somewhat more complex actions required, and it provides a framework for future condition or specialty-specific applications. So while this report is for all youth and those generically with special health care needs, the feeling of the authoring group was that particular areas such as sickle cell disease or cystic fibrosis might be able to develop an overlay or template alongside of the algorithm for those conditions that may be provide even more specific guidance. The other point about the algorithmic structure that I think is important is that it is in the logical format that is easily incorporated into an electronic health record. And the vendors of electronic health records have indicated their interest in seeing reports such as this provided in an algorithmic structure so that they're easily translatable into the kinds of prompts and templates that electronic health records are noted to be able to do. There's explicit guidance about practice structure and process beginning at age 12 that extends up through the transfer of care into an adult medical home. Next slide, please. So this is a high altitude view of the algorithm itself, and it, as a single slide, would be difficult to visualize. Again, I encourage you to use the links and obtain a copy of the report. The printed version contains the algorithm as a tear-out piece that can be used independently of the article. But the first line reads, medical home interaction for patients age 12 and above. So this is really intended to be guidance through individual encounters. In general, these would tend to be office encounters, though some of the elements of the algorithm might be addressed in a telephone call or in other ways in which youth and families and their healthcare providers communicate. The second line of the report describes age ranges so that, and they each ask a question. Is the patient 12 to 13 years of age? Is the patient 14 to 15 years of age? And so on. And if the answer to that question is yes, then the action in the third row is undertaken. And let me go to the next slide and show you a little closer view. Well, first, just to say that the primary elements contained in the algorithm and in the report about healthcare transition are that it needs to be, support needs to include preparation, assuring that young adults are ready to manage their own healthcare as independently as possible, a process of planning that assures that the healthcare transition needs have been anticipated and the responsibility is clear about who will do what when, how will the youth be involved, how might a parent be involved, how will physicians, providers, and other office staff be involved. And finally, that there's an implementation, that there's an explicit and intentional implementation process that actually assures a smooth and seamless transfer of care. The next slide is the closer-up view of the top 3 rows of the report that you may be able to see more easily on your computer screen. But as I mentioned, row 2 are the various age ranges, and row 3 are the action steps. And this report begins with a process at age 12. The authoring group acknowledged that there may be aspects to healthcare transition that actually begin before age 12 for some patients, which have to do with developing skills in self-care, so that younger children may learn to administer their insulin if they have diabetes. They may learn to test their urine if they have a kidney disease, and so on. So there may be educational and self-care processes that occur before age 12. But focusing on the actual transition of healthcare itself, the authoring group and many of the respondents agreed that by age 12, youth and families should be aware of the healthcare transition policy of the practice in which they're receiving care. And this sort of begs the question of whether or not a practice actually has a healthcare transition policy. But as the text of the report indicates, it was a feeling that this was actually a very important step for practices to provide better support for healthcare transition, that they have a written approach or policy. In some settings, policies have a loaded connotation and legal implications, but that they have a written approach that they can point out to their staff members and point out to youth and families that this is how they undertake supporting healthcare transition. This is when they anticipate transfers of care to occur, and so on. And really at age 12 or 13, that's the primary action step. When a child returns in the 14 to 15-year-old age group, the action includes assuring that step one is completed, that the family is aware of the healthcare transition policy, and to initiate a jointly developed healthcare transition plan with youth and parents. And the assumption about this healthcare transition plan is a developing and kind of iterative document that's part of the medical record, and that it may have fewer elements at age 14 and 15 than it might have at age 17 or 18, but that it becomes something to which both providers and families and youth refer at each office encounter from at least age 14 onward. And again, age 16 and 17, the transition plan is reviewed and updated, and further assessments of preparation and readiness for adult care are completed. And I should say that the report as a whole, again, has fairly extensive texts that elaborate on each of these diamonds and boxes that you find in the algorithm. And when the patient reaches 18 years of age, so if the patient is 18 years of age or older, there needs to be assurance that the previous steps have been completed. And at this point, unless there is some arrangement or indication to the contrary, an adult model of care should be implemented. Law requires that an 18-year-old patient be assured of privacy, and that a discussion is undertaken about how and in what ways to engage parents and family according to the youth's preferences. This is worded in this way for the benefit of the family physicians who were part of the authoring group, who felt that in many cases, if they had provided the pediatric care, they will not be transferring care to an adult setting because they'll provide the adult care as well. The same is true of med-peds physicians. But in any event, the transition that the youth is experiencing to adulthood is still undergoing its kind of relentless biologic process, and as such, a more adult approach, an adult model of care needs to be self-consciously implemented at around age 18. The next slide, please. If I could have the next slide.
Sure. Sorry about that. There we go.
There we go. And this is a close-up of the bottom half of the algorithm, which is the branch related to the question, does the patient have special health care needs? So at any of the age segments that are in the part that I just described, age 12 to 13, age 14 to 15, age 16 to 17, and so on, this question is asked, and if the answer is yes, then there's a process of incorporating transition planning into chronic condition management. And this includes consideration of how specialty care will be taken care of for a young adult. Will there be a transition to adult specialty providers? In some instances, there are not obvious adult counterparts to some pediatric subspecialties, so that the adult care may remain, at least for a time, in the pediatric subspecialty world, but and an additional list of questions that may relate to issues such as guardianship or custodianship, and relate to what might be a more complex array of medications and health history and so on. That leads to the question of whether or not age-appropriate transition issues have been addressed related to the chronic condition. This may require follow-up interactions by office visit or telephone that are more frequent than for children without any special health care needs. And then finally, the transition component of this particular interaction. So the circle at the bottom that completes the algorithm is really meant to be the completion of the particular office encounter or interaction that began at the top of the algorithm. And then at the next encounter, the algorithm is activated all over again, and the issues it identifies are addressed. The next slide, please. So the intention is, and obviously the value of this is only if some sort of effective implementation occurs. The intention of the report is to assure that transition planning is part of each adolescent age office visit, that there's a coordination of transition-related activities for children with special health care needs. If the office as a medical home has someone identified as an office-based care coordinator or someone in that role, for this particular purpose, that office staff member may also be the transition coordinator or navigator. That there's active involvement in the identification of adult primary and specialty care providers. It was the unanimous opinion, I believe, of the authoring group that it really was the responsibility of the pediatric world to assure that there is the specific identification of an adult primary care provider and a specific plan, at least, for the location of specialty care, and to engage in that process of identification, and that there's active communication of useful information to new adult providers, what we've begun to call the transition package. And this means that there may be phone call or an email communication or a very succinct package of materials that meets the needs that we heard adult providers had with respect to transition. The next slide, please. Portable medical summaries are repeatedly identified by adult health providers as a need. They need a short 1, 2, maybe 3-page summary of the individual's medical history, current medications, preferences with regard to care, specialty, and other resource involvement, etc. And particularly for those conditions of childhood onset that are unfamiliar to adult providers, a short condition-specific fact sheet that describes the condition that can become part of an individual's medical record. There are examples of this being developed in a variety of areas. The genetics world has developed what are called ACT sheets that describe genetic conditions around very young children, as well as more and more around transition age youth and young adults. The availability of the pediatric provider, the former primary care provider, as a consultant to the new adult primary care provider. And there's some models for doing this and some opportunities that allow a billing for such consultation. And as I mentioned, direct communication with the new adult provider. The next slide, please. One of the things, this is a concluding slide, but I wanted to mention before leaving the topic of the algorithm, there's a heavy weighting of the algorithm towards the pediatric side of the transition bridge. But we're becoming increasingly aware that the adult side of that bridge is in need of attention, and I'll get to that in just a minute with my final slides. But for those of you who are in practice settings on this call, and maybe those of you who work with individuals in practice settings, we'd like to provide a list of doable activities that could take place in your setting in the next month. One would be simply to read and share with your office staff the new clinical report, and to discuss it at an office staff meeting regarding how portions of it might be implemented in your practice with an aim towards implementing the entire algorithm eventually. Identify a responsible champion or person on your practice team for focusing on improving healthcare transition in the office. Such improvements are usually difficult to achieve without someone assuming some responsibility for it in view of the fact that everyone is in general so busy with their usual activities. Draft and adopt a healthcare transition policy. Those of you who don't have a written approach or policy related to transition should do so and share it with your staff. Adopt a healthcare transition checklist, and consider starting a registry of youth approaching adulthood in your practice. And sort of intentionally or actively support the identification of adult medical home for 2 youth leaving your practice during the next month. This is a suggestion of trying to identify at least 2 of these bullets that might be something you could implement in the coming weeks. The next slide. I just briefly wanted to touch on the National Healthcare Transition Center because a lot of our objectives were developed with some foreknowledge of what the clinical report was going to look like and its algorithmic structure. And center to our activity is the implementation and support for 4 year-long learning collaboratives in diverse geographic areas involving both pediatric and adult practices. We're using standard learning collaborative breakthrough series methodologies to help these practices implement the clinical report algorithm. To simplify that process, we've developed what we're calling the 6 core elements of healthcare transition, both for the pediatric side of the transition bridge and for the adult side. We'll also be supporting 4 additional sites in healthcare transition implementation using the 6 core elements, and then disseminating the implementation tools in this healthcare transition package through the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Physicians, and other partners. The next slide, please. This again is hard to read on a computer screen, but it is what the 6 core elements look like. It's a 1-page summary, and the package of transition supports that we're developing as a whole provides tools that are linked to each one of these 6 elements, so that there's at least one tested tool that is connected with each of these elements. And that, as a package of improvement tools, is going to be available on our website in the near future. The next slide. And this just provides resources that we've described, links to the webinar slides that you've been looking at, links to the clinical report so that you can download it in its entirety, and also a link to the 6 core elements of healthcare transition on our website. The next slide.
Thank you so much, Carl.
Sure.
At this point, I'm going to be selecting some questions of those that were sent in. We have several really good questions here, and I'm going to direct this one to you, Carl. Can you address how the transition plan or algorithm incorporates the needs of children and adolescents with developmental disabilities and their families?
Yes, and again, walking through the clinical report, I think fails to reveal the richness of the text of the clinical report itself, which elaborates on a variety of issues. There's a fairly long section in the report on the approach to children with special health care needs and approaches to chronic condition management. And it addresses the issue of individuals who may have a cognitive disability or other limitations in their abilities to manage their own health, and the considerations that families may need to give to that, and that practices need to be ready to support. Again, as I mentioned, the intention of the report is for its broad application and for areas of special interest, and this might include groups or specialists interested in developmental disabilities or interested in autism, for example, might use this report and its algorithm as a framework or template for devising a more condition-specific report.
Here's another question, a good question. How do college-based clinics and healthcare systems fit into transition planning? Have they been queried regarding their challenges and needs?
That's a wonderful question. I think that in particular, youth who transition in their lives from secondary education to college, or I think a similar case can be made for thinking about a transition to the military, both of which may have healthcare systems of their own. One of the concerns is that there is seamless access to a primary care medical home. And in the college instance, very often college health services, while they provide high quality acute illness management and may help track chronic conditions in college, they do not necessarily provide a medical home. Many pediatricians feel that their involvement should continue through these years to provide sort of stability and longitudinality to care, and that the transition to adult care might happen after college. I think it will be important for those of us involved with this clinical report to ensure its dissemination to college health services, and to consider discussions with as well with the military healthcare system.
Great, thank you. Here's a question directed to Mallory. Mallory Sear noted that her transition was successful because she interviewed and chose adult doctors. Yet one of the primary barriers to transition is lack of adult primary specialty providers. Mallory, can you comment on the resources you use to find adult providers?
I honestly was I just totally lucked out. I switched insurance companies when I got a new job, and I transitioned to a family practice after going to a pediatrician for my primary care. And so they simply gave me the name of someone who was taking patients, and we happened to really kind of hit it off and have a good relationship. But that is something that I've heard quite a bit about, and so my suggestion would be to either use a website, Google, local provider finder, go through your insurance company and the connections that you have, and see kind of those different outlets where people are taking patients. But for me, it just happened that the one place I went the first time, they had openings. So.
Thanks, Mel. This is a question that's somewhat related. Who selects a young adult's new specialist, the pediatrician or the adult care provider? Carl, do you want to take that one?
Yeah, I can answer that, or I can attempt to. Part of the difficulty with that question that many families sort of have experienced is that the answer may depend on the individual, on their chronic condition, on the availability of adult subspecialists. I think that the model for this mainly needs to be explicit. In other words, it needs to be clear to the family and their pediatric provider how this part of a transition is going to unfold, and it needs to be planned in that way so that the pediatrician who's been involved with the family since birth perhaps might orchestrate the specialty care transition with the family. On the other hand, it may be determined that an adult primary care medical home is more well-positioned to engage the adult care providers and might so that the primary care transition might happen initially, and then the specialty care transition may follow. So I think the key to this is not so much what the right answer is, but that there is an explicit plan for how this issue of specialty transition is going to take place.
Thanks so much, Carl. I want to note there are several really good questions here that are posted, and we are about out of time. So I want to just remind people that we will be compiling these questions along with the answers and posting them on our website. So please look for those. And this comes to near the conclusion of our webinar, and I just wanted to make a few closing remarks. I wanted to urge everyone to stay connected to Got Transition. You've seen several references to our website, so I would really encourage people to get on our website, sign up for our e-news so that you can be posted about coming events and other webinars coming up. We want you to follow us on Facebook. We'd love to have you post a comment about this webinar, for example. On our home page directly will be the audio archive of this webinar, and as I said, the question and answer from this webinar will be on soon.
So that, Anne, this is Carl, all of the
Sure.
questions we'll attempt to do a sort of written document version with responses to all of the questions that people have answered, in addition to those that we've addressed on the call itself.
That's right. I want to thank everyone for participating in this webinar. I wanted to let people know that there'll be an evaluation that will be sent to everyone automatically. Please complete that and share with us your transition topics of interest. If you have any questions or comments, my email is listed there below. At this point, I wanted to issue our apologies to Patience White for the technical difficulties that precluded her participating in this webinar. We're very sorry for that.
And we want to make sure people understand that she's made every effort to be aboard and joining us, and we'll try to incorporate her thoughts into the Q&A responses that we'll be attending to.
And this concludes our webinar, unless you have any closing comments to make, any Carl or any of the speakers.